Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Yes. So everybody, I welcome you again for today's class. We've taken a topic called hypothyroidism in pregnancies. Not very common to have just a case on hypothyroidism alone. It is not a very big, not a very huge case. But the reason for me taking this class and for the students to demand this class is mostly because usually you will find somebody who's in your exam as a patient of maybe FGR along with hypothyroidism, or preeclampsia along with hypothyroidism, or stillbirth with a history of hypothyroidism. How to associate, how to go about with the viva. Suppose the viva goes into that direction, you should be well versed, you should not panic, and for that you need to have knowledge. So in the class today we'll be talking about these thyroid disorders in pregnancy, all of them, not just hypothyroidism alone. The class name I've put as hypothyroidism because that's very, very common, but we'll be talking about all the thyroid disorders. So I begin the class today and I welcome Shreya to the presentation of the case. It's a very, very simple case, but we will be taking you through, like I always do. When it's a case of just anemia and pregnancy, we go through the entire spectrum of anemias, all kinds of anemias. Of course, that's a very extensive class, but yes, when it is hypertensive disorders, be it gestational, I take you through preeclampsia and then eclampsia and the disorders and the complications, right? In the same way, it is just hypothyroidism, but we will touch upon Graves' disease, postpartum thyroiditis, so on and so forth. And you'll see how I construct the viva, the way it's going to be in your exam. All right, Shreya, you can start your case.
Presenting a case of Mrs. X, 33 years female, resident of New Tipasandra, Bangalore, doing job in a private company, studied till BCom, wife of Mr. X, doing private job, belonging to upper middle class by modified Kupuswamy classification, was admitted and examined on 24th of August 2024. Last date of period was of 6th of December 2023 and expected date of delivery by LMP is 13th of December 2024. Period of gestation is 37 weeks, 1 day. And obstetric score is Gravida 4, Para 1, Live 1, Abortion 2 with previous LACS.
Okay. So we have a patient who's come to us at, she's 4th Gravida, Para 1 and L1, and 2 abortions. Okay, remember this history, and she's a case of previous cesarean. And right now she's 37 weeks, and okay, let's hear the complaints. Yeah.
Chief complaint, ma'am. Gravida 4, Para 1, Live 1, Abortion 2 with previous LACS with history of 9 months of amenorrhea came with complaint of decreased fetal movement since morning, felt only 1 to 2 movements, no complaint of pain abdomen, PV leaking or PV bleeding.
Okay, so she had a complaint of just decreased fetal movements, and that is why she's come to you. And she, along with that, she's got no pain, no history of leaking PV and bleeding PV, and I presume this is the first episode of fetal movements, decreased fetal movements.
Yes, ma'am.
Guys, I hope you were there in the class which I took on decreased fetal movements. We took a class on decreased fetal movements.
RH negative, ma'am.
Sorry, RH negative. Yes,
with RH negative.
Very good. Thank you, Shreya, because otherwise my students would have started, searching in the case presentations in decreased fetal movement. It was, a class on RH negative, but that patient came with decreased fetal movement, so we took it as an opportunity to include decreased fetal movements in that case discussion, because there is a complete guideline by the Royal College on decreased fetal movements and how to manage a patient with decreased fetal movements. The most important quintessential part of that guideline is whether she had a first episode or she is a high risk patient or she's had repeated episodes of decreased fetal movement. So the moment she becomes high risk is when she's been coming to you again and again with decreased fetal movements. That is when you take her seriously. And if she's already a high risk woman for stillbirth at any point in time, maybe she's a history of severe fetal growth restriction, deranged Doppler flows, or a previous history of stillbirth, bad obstetric history, or some complication in this pregnancy which can lead her to having a stillbirth like IHCP or something. So which is why we will be very alert when such a patient gets history of decreased fetal movements, right? So the entire viva, the entire questionnaire, how to go about such a case is thoroughly discussed in that particular case, which is why I'm not focusing in this particular case on that particular problem. Okay, so I understand that she's come with the complaint of decreased fetal movement, but my Viva will be centering more on hypothyroidism because that's the case today. Yes, Shreya, you can continue. She came to you with decreased fetal movement since morning, and she's only felt about 1 to 2 movements since how long? Since morning?
Yes, ma'am. Since morning only she felt 1 to 2 movements.
My God. And she was having food and everything. She was not fasting, I suppose.
No, no, ma'am, nothing.
Okay. Have you taken a history for this particular part, or do we? Okay, I'll ask you like
No,
that.
ma'am, I have taken, ma'am. I have taken in the third trimester.
Okay. And there's currently no history of any pain abdomen, PV leaking, bleeding, though she's around 37 weeks already. All right. Let's hear the obstetric history, then we'll be able to understand it better. Yeah.
Ma'am, history of present pregnancy, first trimester history. It was a spontaneous conception booked case. Pregnancy confirmed after 2 months of missed period by urine pregnancy test. Folic acid taken, first dose of TT taken. First trimester scan was done. It was found to be normal and corresponding with date, and she was advised to take tablet EcoSprint 150 mg, she told, in view of decreased blood flow to the baby. And she was a known case of hypothyroid since 12 years, and she was on tablet Thyronorm 100 mcg. She was advised to increase the dose to 125 mcg on Saturday, Sunday, and continue the same dose of 100 from Monday to Friday. No history of excessive vomiting, fever, rashes, burning, micturition, spotting, or bleeding PV.
Okay. All right. Shreya, certain questions I have for you here, and then I'll ask my class of intelligent students certain questions. First of all, she's been taking EcoSprint, and the lady was told to take it because of decreased blood flow to the baby. Okay. Now, tell me the reason for giving EcoSprint to this person, according to you. Why do you think is there an indication to give EcoSprint?
Ma'am, later on when I inquired, I got to know that in her first pregnancy, she had hypertension. And
Okay.
she had also a history of Down syndrome, ma'am, in the
Okay.
second abortion.
Okay.
So I think mostly because of that, because what she told is because of the decreased blood flow to the baby, the doctor advised me this tablet.
Mm-hmm. So I'll tell you what it could be, Shreya. See, there was a guideline that had come. See, since a long time I've been involved in seeing these guidelines as per the European guidelines, the Royal College and the Irish guidelines and all. But there are more guidelines in, from FIGO. There's a guideline on screening of preeclampsia and the measures to combat preeclampsia once the screening is positive. Out of them, there are multiple tests, of course. The few tests I think we discussed yesterday also. There was a question that had come on screening of preeclampsia. So certain tests which are giving is a positive result for the development of preeclampsia later on. If those tests have come to be positive, she can be started on EcoSprint. So a part of which we were discussing in one of the classes, that uterine artery pulsatility index, if it's more than 95th percentile, that is telling us it's a predictive factor for the development of preeclampsia, not the uterine artery Doppler alone. Number one, that is one reason. The other history that you were giving, a very positive history of a previous history of preeclampsia and the previous pregnancy, is a high risk factor for the development of preeclampsia, and this is according to the Royal College. The first one, the uterine artery, is according to the FIGO classification. So when I was discussing in the class yesterday, there are certain factors which are high risk factors, screening high risk factors for the development of preeclampsia and the pregnancy. As much as I can remember them from whatever I remembered, is number one, the history is of course very important. Remember, I spoke to you about the gestosis scoring that we were doing. That is definitely important. The previous history of preeclampsia, the previous history of a preterm delivery due to a preeclamptic episode, the previous history of fetal growth restriction, any chronic hypertensive, chronic kidney disease, all these are high risk for the patient to develop preeclampsia in this particular pregnancy at whatever point in time. The other will be markers like uterine artery Doppler. So if your uterine artery Doppler, I'm talking uterine artery, not umbilical artery, because umbilical artery is associated with FGR. Uterine artery Doppler, if the pulsatility index is rising, and if it has crossed the range of 95th percentile, that is also, according to FIGO, not according to the Royal College, is a high risk marker for the development of preeclampsia. Probably that is why she said that. And of course, the other reason that you're giving is that she's had a history of preeclampsia is definitely important. Apart from that, also there are many other factors which are high risk factors, and there are certain these placental growth factor, SLT ratio. These are also the markers for development of preeclampsia as per FIGO. So if these factors are positive, she can be well enough started on Neosporin, which is now a known pharmacological agent to combat the development of severe preeclampsia in the early trimesters of pregnancy. Okay, so maybe that was the reason. And of course, when you took the history, she said she had a history of previous episode of hypertension, which makes her high risk for developing hypertension in this pregnancy. Yes. And now I like to ask my students who are there in the class. Yes, thank you, Nikita. Thank you, Usha. Thank you so much for remembering and revising with all of us, because all these things, everyone is going to remember. Everyone is going to remember, right? So we have a different score for, the high risk scoring for aspirin and the moderate scores for aspirin. I remember them by my heart. But the thing is that that's as per another guideline. I was revising another guideline with you. But of course, it's there in the answer bank now that I discussed it just yesterday. So you can go ahead and look forward to that answer as well. Now, the question to the students in the class about this known case of hypothyroidism. She was in 12 years. Tell me what happens to TSH in the first trimester and why? Just the answer for this question, that what happens to TSH, the thyroid hormone TSH, in the first trimester and why? Why does TSH decreases? Okay, everybody establishes that TSH decreases. Can you tell me the reason why it decreases in the first trimester and why it should not be taken too seriously, which is why we should not fluctuate the dose too much? We should rather go in for seeing the free T3 and T4, right? Until unless, it's a very small difference and we can just ignore it and go ahead. First trimester is very important for the cognitive, mental, neurological development of the child. And at the same time, very important in the fluctuations of the thyroid level. So you should know the pathophysiology. Now tell me that. What happens? Very good, Nikita. Very good, Usha. The problem agent is HCG. So what happens is that the HCG molecule has got very similar characteristics to that of the TSH. HCG is increasing. Body perceives it as TSH. There is a negative feedback loop and TSH kind of decreases. And because of why? Falsely, you're thinking that if there is hypothyroidism, TSH goes low. You do not think that thyroid is increasing because of that TSH is going down. It gives you a feeling, it gives you a look as if, because thyroxine is increasing, TSH is decreasing. That is not the case. Actually, what happens is that the HCG molecule is leading to the TSH decrease. Do not club it. Do not confuse it with hypo. In fact, the picture seems like hyper. Okay, so you have to know that you're not going to supplement unnecessarily or decrease or increase the dose of thyroxine just on the basis of the first trimester. That's my point. In our case, we increased, right? We increased the dose from 100 to 125. The reason was her thyroid profile was changing. Shreya, did you see the reports with the patient?
Yes, ma'am.
So
Ma'am,
her TSH was rather increasing. Yeah.
Yes, ma'am.
So TSH was increasing more than it was before. Probably she had an imbalance maybe to start with. Okay, because usually TSH is going to rather decrease. In that case, it's sufficient and understandable enough to increase the dose of thyroxine. But the other actually is the more prevalent condition or more physiological condition, right? So if anybody has maybe an initial starting of hypothyroidism, it will rather be masked, because actually TSH instead of increasing usually decreases in the early part of the first trimester. I hope I'm clear, guys. And if I'm not clear, please ask me to repeat it. I would love to repeat. The idea is HCG is molecule similar to that of TSH. It falsely perceives that TSH is increasing and it gives a negative feedback loop. So TSH, despite the fact that it should or shouldn't increase, it actually starts decreasing. So even if you're developing hypothyroidism, it gets masked. TSH rather than increasing is decreasing. This is what I wanted to say. All right. Since we are here on the first trimester, Shreya, just let me know what exactly happens to the TBG, what happens to the total thyroid levels, to total T3, total T4, what happens to free T3, what happens to free T4. We talked about TSH.
Yes, ma'am. Ma'am, thyroid gland in pregnancy, as we know, increases in size by 20 to 40%. Iodine requirement increases by 50%. T3, T4 increases by 50%. Renal excretion of iodine increases. Total thyroid binding globulin increases because of the effect of estrogen.
That's right. So if TBG is increasing, what happens to the level of free T3, T4?
Ma'am, free T3, T4, it will be, ma'am, constant only.
It will
or
usually
below?
decrease if TBG is increasing. Say binding globulin is increasing, it might decrease or it might remain normal. Okay,
Maybe normal.
but yeah, what happens to the total T3 T4 levels?
It will increase.
They increase mostly because of the presence of estrogen hormone. Okay, and what about the iodine requirement in pregnancy? Tell us that also. Let's finish.
Iodine requirement in pregnancy will increase by 50%, ma'am.
Yeah, and what exactly is the idea of iodine?
Ma'am, in pregnancy, it is 250 mcg per day.
Yes, microgram per day. Absolutely. In breastfeeding, it will become to maybe around 300 micrograms.
290. Yes, ma'am.
Yeah, 250 to 250 in the pregnancy, 300 around in lactation. That remember that. Okay, this was actually just the physiological part. I thought I'll just finish here because we're talking about the first trimester. This is what happens. And tell me the cutoff also, Shreya, over here. People have a lot of confusion regarding that. So what exactly are we finding as a cutoff of thyroid? What should we take as a cutoff to supplement or not supplement the thyroxine?
Ma'am, it depends on the trimester wise. Like his first trimester, it should be between 0.1 to 2.5 milli international unit per liter. And second and third trimester, it should be between 0.2 to 3 milli international unit per liter.
Okay. Now, what Shreya is saying is also right, and what I will tell you now is also right. Please don't get confused. I'll try to improvise the same answer. They say that actually 2.5 in the first and 3 in the second and third trimester. Shreya, please correct me if I'm wrong. Okay. In the second and third trimester is the correct thyroid range. TSH should be around in this range. But they also say that from 2.5 to 4, if the level goes somewhere between 2. Let's say in the first trimester it is 3. Would you treat this patient or would you not treat this patient? You have to go also for the anti-TPO antibodies. If the anti-TPO antibodies are positive, yes, you may treat this patient if the TSH level is 3. But for all other patients in which anti-TPO antibodies are not present, they are not at high risk, they don't have any heredity or any other factor of hypothyroidism, there is not much benefit of treating this patient between 2.5 to 4. That is what they say. Above 4, definitely you have to treat. Okay, and there'll be an algorithm which I think I'll be showing you. It was there in I think EOGD bulletin also. I don't know from which exact guidelines is that, but yes, there is a bulletin which shows about a small algorithm that shows that if the anti-TPO antibodies are present and the level is between 2.5 to 4, you may consider giving thyroxine, you may consider treating her. But if there are no anti-TPO antibodies present, in that case, you may not treat this patient with added thyroxine. Above 4, again the same thing, anti-TPO you will, and if they are not present, you might not consider it, but above 10 you have to. But that is an extreme. I would rather say above 4 you have to treat all patients. Now let's finish one more thing over here. What about universal screening? Is there a universal screening of thyroid hypothyroidism in India? Do we follow that?
No, ma'am. There is no universal screening according to Ministry of Health and Family Welfare in India. Only for high-risk pregnant female we should screen.
Okay. And what do you mean by those high-risk pregnant patients? What do you mean by that? Who are
high-risk pregnant patient means those who are residing in the endemic belt, or those who have history of thyroid dysfunction or any thyroid disorder, or they are having any history of head and neck radiation, or they are having any other autoimmune disease, and or any history of bad obstetric history, recurrent pregnancy loss, or any family history, then we should screen for the patient.
Okay. So that means you're not universally screening all the patients for hypothyroidism, only these particular patients who are coming from that particular endemic belt. And do you know these endemic belts in India? Okay.
Yes, ma'am, northeastern states.
Wait. Okay. What about my other students? Who all are the endemic belts in India for hypothyroidism? This is so important, guys. This is so important. What are the endemic? Which is the endemic belt in India for hypothyroidism? Yeah, IOGD bulletin. Yeah, even I enjoyed studying from there. It was great, nicely given. Yeah. If you don't have time, guys, just learn, just read through AOGD bulletin for hypothyroidism in pregnancy. It's well enough. It's pretty good. If you want, we can share it also over here, but it's the IOGD bulletin. Everything is there in the recent advances. I put it there because even I enjoyed studying those topics from there. Yeah, not these mostly. Yeah. In fact, a lot of, patients from Bihar, Odisha, these places, surprisingly they have, though actually it's more, prominent in the hilly regions because there you have less of salt, deposited, the entire salt and everything gets washed away, and it's more in the, foothills. Unfortunately, it is not the condition. You have more in case of these places I've seen. Every second, third person is hypothyroidic, right? And now so many people of this kind, they've migrated in different parts of India and they have their progeny there. And as a result of which now the entire India has so much, especially North India, has a lot of, hypothyroidism cases. Correct. Absolutely right. Let's move forward, Shreya. This was only first trimester. Let's go ahead. Yeah.